So thank you to everyone for joining us today for our Q&A session. I'm Christie, I'm the Head of Patient Services for the PBC Foundation, and I'm really pleased to say we've got Dr. Andreas Kremer joining us again from Switzerland today. Thank you so much for taking the time to join us again. We really do appreciate it.
Yeah, it's a big pleasure to be on board again. Also, warm welcome from my side.
Thank you. Thank you. So just before we start, I do have our usual little disclaimer before we start. So just to remind everyone that these Q&As don't take the place of a consultant with your own clinician. In these sessions, we're aiming to provide some general medical information and not medical advice. Also, please be mindful if you've joined us on Facebook, that is a public forum. And for more privacy, you can join us in the meeting room here and click meeting with the doctor and I. And that's a bit more private. So I'll get started with the questions that we've had sent in so far this week, and then I'll keep an eye on the live sessions, both here in the room and on Facebook, to see if we get any new questions coming in. So just going to start with the first one that we've got in today. So what we've got is it safe to mix urso suspension into a smoothie with vitamins and other medications to take once daily?
Yeah, that's a good question and a regularly asked question. So when we talk about urso, deoxycholic acid, it's important to know that it is a part of the bile acid pool which needs to be homogenized within the existing bile acid pool. And we know that ideally the first 3 months we take this drug in the morning and in the evening to have a better homogenization with the existing bile acid pool. And after 3 months, I tell my patients that it's okay to switch to one single time point. I wouldn't do that beforehand. You have to imagine that bile acids circulate within the enterohepatic cycle 8 to 10 times per day. And ideally, we get an optimal mix if we start that at least twice daily in the beginning. After 3 months, I think it's okay once daily. There is no problem with mixing with drinks or eat fruits with it along or milk. I don't see any problem here. The only exception, and this is important, there are patients who suffer from pruritus and they may be prescribed anion exchange resins. And these anion exchange resins, such as cholestyramine, cholesevelam, cholestyramine, and so on, they all interfere with the uptake of urso. And these need to be separated for at least 4 hours. So ideally, cholestyramine or anything like this is taken, let's say, for the lunch time, and for the evening, even late at night is good for these anion exchange resins to interrupt this night cycle, cycle of the enterohepatic cycle without interfering the uptake, which then can take place in the morning.
That's great, thank you. And a good point there, just to mention the cholestyramine as well for anyone that's taken that, just to make sure that they're considering that with their urso dose as well. So thank you. I'm taking it slightly out of sync today. I've got two other urso questions that I was going to sneak in just before we move on to the next one that's on the list. So one of the questions is, does urso reduce itching?
Yeah, I personally think on the long term, there are patients who will have a benefit on itching if the underlying disease is adequately treated. So initially, urso may worsen pruritus. It can even, be very bothersome if we start with too high doses. So there are patients who tell me if they start with 1,000 milligrams per day, that itching becomes very severe. That's not very common, but this can happen, as it does with obeticholic acid. But per se, if we titrate that in and if we look at the benefit over months, then there are patients who will have a benefit on urso. But looking at the clinical trials which have been done and looking at large patient populations, in general, it seems as if urso does not significantly has an impact on symptom burden and in particular, pruritus is a considerable patients on many patients being on URSO, and these are patients who have taken that for months to years, decades even. And so in general, I would say no, but there are patients who will have a benefit if the underlying disease is efficiently treated. We see it once again that yeah, there are patients who will have a benefit on itching, but the broad spectrum of patients has no significant impact on so far all existing in-label therapies, and the same holds true for the second-line therapy, obeticholic acid.
Thank you. Another question is just around, as a more general one, please can you talk about weight gain after starting URSO? We know a lot of patients report weight gain.
Yeah, that is true. This has never been studied in a real good extent. Actually, it would be worthwhile investigating that to objectify that. These reports are there. I also have patients who told that to me. I don't know to which extent this is really long lasting. So whether this is a temporary effect, which is then diluted and disappearing over a longer treatment period. I know those patients. There are also patients reporting on other problems. In principle, yes, this can be an adverse event of this treatment, but keep in mind it's a endogenous substance, and it's very safe. There are, except for these milder adverse events, it has a very good safety profile. Even in advanced disease stages, we can use it very safely, and it has the best effect even on hard clinical endpoints, so overall survival, transplant-free survival, even if we do not have a complete response, or even if we don't have a laboratory improvement, URSO is of benefit. So I would think this weighs certainly these side effects out in the end.
Actually, just following on from that, we've had a question here in the room and also one on Facebook around hair loss. How worried about hair loss should I be on URSO? And one in the room here just asking about a potential treatment for hair loss. So another potential side effect for URSO.
Yeah. I personally do not believe that URSO causes hair loss. I rather think these are other diseases which coexist with PBC. For example, hypothyroidism, meaning in a significant number of patients, there is also coexisting diseases, coexisting autoimmune or immune-mediated diseases, such as the Hashimoto thyroiditis. And if we move forward towards a hypothyroidism, this causes hair loss. I think hair loss can be caused by many other diseases and aspects. Can also be a problem with postmenopausal alterations in the hormonal status. So it needs to be objectified. So patients should be notified to really count the number of hairs they lose per day to have a better way of objectifying that. And if this is above, if I remember correctly, I think it were 250 per day, which are then found and counted. I think it's quite an effort to do so, but it's good to have done that for a week or so to have a better understanding how many hair are really lost. And if that's the case, then it needs to be investigated deeper. I don't think that URSO really causes hair loss. I don't think so. It's rather coexisting diseases or other alterations, such as a postmenopausal status.
So in terms of treatment, it's better to look for the underlying issue that might be causing the hair loss.
Absolutely. I mean, of course, we advise to look at other laboratory parameters. We look at zinc, we look at selene, We look at thyroid function and so on. So that would be next steps. And to get a better understanding, we do that together with an endocrinologist. Normally, then we try to figure out what is the most likely cause for this phenomenon.
Okay, thank you. So just moving back to the questions that have been sent in, some background on a patient who we've got was diagnosed with PBC in December last year. This was after them feeling unwell and discovering raised LFTs and a positive AMA in the October. They started Urso mid-December. Their ALP has dropped from 205 to 149, and their gamma GT has dropped from 128 to 49. They had an MRI MRCP scan in January, which showed no evidence of chronic liver disease. Their consultant seems a little surprised by their LFTs and has reduced as much as moving forward he's continuing on the Urso, and having had blood tests 3 months ago suggests if the liver tests remain out of range, it would be worth pursuing a liver biopsy to clarify the diagnosis and to make sure there's no underlying fibrosis. What are your thoughts on that? I think the question is around, could it mean that there's a chance they don't have PBC, or maybe is it too much of an early stage as there's no indication on the scan?
Yeah, I fully agree. I think that it's obvious the diagnosis is adequate. I mean, there are the antimitochondrial antibodies in combination with increased cholestasis parameters. If this is a female person, you have a risk above an age of 41 in 1,000 of these female person have a likelihood to have PBC. So the diagnosis for me is adequate, and the treatment response is good, but we know from clinical observations that the strongest benefit is seen within the first 3 months. Now the treatment is rather 1 to 2 months currently, and I think it's a good treatment response. I could imagine that within 6 to 12 months, there is even a complete normalization of these still slightly elevated lab parameters, and that would be the ideal response to UDCA. So I wouldn't be surprised about the drop. This is typical. It's a steep drop initially, and then after 3 months, it flattens out. Still, we see improvements even beyond 1 year. So for me, this is an adequate and good response. So I would be very happy and rather perform no biopsy. I would perform elastography as non-invasive parameter after 1 year of treatment, so after 12 months. And if their increased values are there and or a significant rise is still present in liver function tests, in liver enzymes, then one could consider a liver biopsy. But if lab values are almost normal and if the elastography is normal, I wouldn't go for liver biopsy in such a patient. This is not necessary in my point of view.
Okay, thank you. There's just another small part of that question that I just wanted to check in around was that they're asking if fibrosis, does that show up on an MRI scan?
No, not on an MRI. On a regular MRI scan, there are magnetic resonance elastography scans, MRE scans, which perform an elastography of the whole liver. These are very, specific investigations, mostly only done in clinical trials. They have the big advantage that they do not look at a small part, a point, or a small area in the liver, such as this is done with sonography-based investigations or the transient elastography. They really investigate the whole liver, so they have a significant advantage over that. But the regular MRI scan is not able to quantify fibrosis. So I would be surprised if an MRE, an elastography, has been done in this situation. An MRCP is good to exclude sclerosing cholangiopathy or other causes, which is obviously not the case. And so in total, this underlines again the diagnosis of PBC in this case.
That's great, thank you. Doctor, I'm just going to jump to a question that we've had in the room here. The patient who put it in, I noticed that they've become disconnected and they've been able to join us again. So I always want to take the opportunity while they're online to ask the question. So the question is, patient is male, had chronic cholangiopathy for 4 years, been told that may have seronegative PBC or PSC. Should they press for a diagnosis? And if yes, what tests do they need? They're on our so, and I've been told that that's helping.
There are many further questions which need to be answered. Of course, we know that PBC is has a female predominance, and that doesn't mean that a male person does not suffer from a PBC. It's a little bit less likely, and we have to think, depending a little bit on the age and comorbidities, whether PBC is the more likely diagnosis, in particular, if autoantibodies are negative. And there, I think it's very important to really exclude all autoantibodies, not only the antimitochondrial antibodies or the subtype antimitochondrial antibodies AMA-M2, which are highly specific for PBC, but also the PBC-specific antinuclear antibodies. These are GP210, SP100 antibodies, anti-centromere antibodies are linked to PBC. And in that regard, it's important to also perform an immunofluorescence if, for example, anti-nuclear antibodies are positive, because these anti-nuclear antibodies are often believed to be, specific or related to autoimmune hepatitis, but this is not the case. If we look under the microscope, then they do not stay in the nucleus. So what the ELISA suggests, anti-nuclear, they rather stay in parts in the cytoplasma. Nuclear dots, nuclear rims pattern are described there, and then it needs further analysis of these antibodies. So seronegative PBC, needs to be verified whether this is really seronegative. If, however, there are really no antimitochondrial antibodies and no PBC-specific antinuclear antibodies, then I always have a problem accepting this PBC diagnosis in a male patient. And then I would definitely look for further causes. And in that regard, the cholangiography, the MR, the magnetic resonance based cholangiography, the MRCP, is of most value to have a better understanding whether there is any sclerosing phenotype, as this is in primary sclerosing cholangitis, PSC, or secondary sclerosing cholangitis. Now, if the MRCP indicates sclerosing cholangitis, then this would not be typical for PBC. This would rather then, hint towards further investigations for a sclerosing cholangiopathy, PSC, secondary causes. Can be many causes, which then needs to be excluded, investigated. And if the MRCP is normal, then I would go for a liver biopsy to have a better understanding what is really happening with the bile ducts in the liver, what kind of immune cells are there, how much they are altered, whether there is bile duct loss, whether there is fibrosis, and so on, to have a better understanding what is really happening on a cellular level within the liver. That would be my approach to answer this question, whether which is the underlying diagnosis. And if the liver biopsy is not conclusive, then the next step would be genetic testing in such a person for hereditary cholestasis syndromes.
The patient has mentioned there just in the chat to say that there was a biopsy done 4 years ago. They thought then it was drug-induced following sepsis. MRCP then was normal, but obviously that was at an early stage because that was 4 years ago. Would you suggest that's something that should be repeated now?
Yeah, I mean, if a patient was severely sick, a sepsis and so on, the sclerosing phenotype may not have been seen initially, and that would repeat an MRCP in such a persisting cholestatic situation. That would be my step, and I would repeat the autoantibodies, including the immunofluorescence. That would be my next two steps. And indeed, it could be that, you know, a severely ill patient can develop sclerosing cholangiopathy. In most cases, this is due to ischemia. Could also be toxic or drug-induced injury. Absolutely correct.
That's great. Thank you. And the patient is noting, yeah, that they were severely ill at that point when they had the drug-induced following sepsis. That's great. Thank you. We'll just go back on to our list here. So the background for this patient is we have a patient who's 47. They've been diagnosed with PBC for 12 months. They're taking urso. They've responded fairly well. Their ALP is down to 142 and all other LFTs are good. Since September, they've been having odd occurrences of heart palpitations, chest pains, stomach pain and dizziness. They've had every heart test possible, including MRIs and ultrasounds, 7-day ECG, but all the results are clear. In the past week, these feelings have been on and off all day, accompanied by stomach pains and a lot of gas. Their GP suspects this is a hiatal hernia, and they are seeing a gastroenterologist next week. Can urso cause this hernia due to the acidity, and will it aggravate the hernia? And may it be an idea to look at an alternative drug?
And that's a good point. It's important to state, despite the name ursodeoxycholic acid, the acidic potential of UDCA is very minimal. So it should not be compared to other acids, as we know that from vitamin C, for example. So they do not change the pH. So urso does not change the pH, does not harm the stomach, does not cause ulcera in the stomach or in the duodenum. It does not influence existing alterations such as hernias, hiatic hernias, for example. They are very common. We see them very commonly. They are not positively or negatively influenced by this drug. So I would not consider the one issue being related with the other. So I would think that urso should be continued. There's a very good treatment response, and AAP is only slightly elevated in this patient. So I think this is per se a good treatment response. All other liver function tests are normal. That's at first sight, sounds very good. All the other symptoms, I think, should be evaluated in a separate investigation. I think a gastroscopy is helpful to have a better understanding. Functional tests, functional diagnostic tests may be helpful. In particular, intolerances for certain nutritional aspects. It could be lactose, it could be fructose, it could be sorbitol, and other aspects. So these need then to be addressed by a stepwise approach, and otherwise, also the heart story, the palpitations are normally supraventricular or ventricular extrasystolic events, which should be discovered by an ECG. But important is that there is no arrhythmia. And during a 7-day period, if no arrhythmia was present, then it's typically these extrasystolic events. They are difficult to be treated if they bother the person, but they are not dangerous. And I think this is an important aspect to mention here. Arrhythmia needs to be treated and can be potentially dangerous. If that is not the case, extrasystolic events are doing these palpitations, difficult to treat, but per se not dangerous or harmful to the patient. And I think this knowledge and knowing that there is nothing really this is not a real harmful situation for me helps a lot of patients. And then it all the other aspects for the GI symptoms needs to be investigated by a stepwise approach.
That's great. Thank you. background on our next patient is a patient whose cholesterol was 8 before diagnosis 18 months ago and now down to a respectable 4 with being on statins and urso. Question is, will they need to stay on statins for life, or will the urso be enough now as it's helping with the bile buildup? Their GP was afraid to put them on statins because of the high liver enzymes reading before the PBC diagnosis.
Yeah, that's a good point. I think it's important to know that in PBC patients, LDL, so low density lipoprotein, the so-called bad cholesterol, that this is increased, but not due to a real LDL. It's rather due to a cholestatic lipoprotein called lipoprotein X. And LPX runs within this LDL fraction if we do the lipid phoresis, so the separation of the load of the lipid density, low and high and intermediate density lipoproteins. And so with regular tests, we cannot separate that. So we need very specific analyses, but per se, actually, we do not have to do that. We treat the increased cholesterol or the increased LDL only in those cases in which there are additional cardiovascular risk factors. And additional cardiovascular risk factors are importantly a family risk. So if the brothers, sisters, the parents have had a heart attack, an apoplex, any other cardiovascular event, or if the patient is smoking, or if there is diabetes mellitus present, or arterial hypertension, to mention the most 4 common causes for increased cardiovascular risk. If they are present, one or more, or if diabetes is treated, it's well controlled, but it's treated, then I would go for a statin lifelong. Statins are normally well tolerated and are not harmful for the liver, even in cirrhotic patients. It's rather the opposite. We rather have data that they are beneficial for the liver. There may be some patients where we see increased liver tests, but then normally a switch of the statin from one to the other. They're category 1 and category 2 statins. So a switch from one to the other category can be helpful in those cases where increase in liver tests have been observed. If now the hypercholesteremia was only treated because the LDL or the cholesterol was so high and there are no other cardiovascular risk, I do not see the need to prolong this treatment. Then I would rather stop it again. But it has to be kept in mind that URSO will not improve LDL in the blood.
Okay.
Despite the fact that the cholestasis extent is improved, but this lipid alteration which we observe in these cholestatic diseases is not improved.
There's actually a couple of questions on statins came in on our live Facebook as well, so I'll just cover them just now as well. So we've got one sort of more general, which I think you've already answered, but I just wanted to be specific on it, is can PBC patients be prescribed statins? And the next one is, I have to
yes.
a patient who has taken a statin for cholesterol, but they're also sensitive to muscle aches. Which statin is liver friendly, and what would be the recommended dosage?
Yeah. The muscle aches, that's a good point. This is an adverse event of statins. So if you have muscle ache, you should go to your GP or a gastroenterologist or who prescribed the statin. Then I would control for the muscle enzymes, creatine kinase, for example. And if that is prolonged or the CK levels are increased, then I would stop the statin, control again the lab values until it's normalized, and then do a re-exposure with another statin. Normally that works. So the switch from one statin to the other is successful in many patients. If not, then there are other treatment options to reduce cholesterol levels if there is a clear indication. But normally a switch is helpful. Now the dose is very different between the statins. There are tables. They are more modern, more potent statins where we need less milligram to have the same drop in cholesterol or LDL. The dose depends very much on which statin is used. And I would start if there are any problems with the lowest dose and rather titrate up than going down if there are adverse events. So I would rather take the lowest dose, check for tolerability, for liver enzymes, for CK levels. And if they remain normal, then I would go for a stepwise up titration until the reduced, wanted reduction is achieved in cholesterol levels.
That's great, thank you. We're moving on to some other questions that have been sent in since we've gone live. So there's a patient who's pregnant and been advised that she was healthy enough for the pregnancy, so no issues were highlighted. She was previously in the US and has now moved to Spain and is 37 weeks pregnant. Our new liver specialist is now advising that she shouldn't breastfeed as it's not known if urso can be taken while breastfeeding. But she does refer to a specific, I think it's a trade name for urso. Is it ursobilane? Trade name for it. And through her own research, she's seen that ursodiol, which is a type of urso she took in the US, would be fine while breastfeeding. Just if you had any advice around that.
Yeah. There is always, if you look at the label, there is always a statement that there is no data on early pregnancy or breastfeeding. But from the clinical experience we have and, international tools and online, toxicity checkers such as EmbryoTox, URSO is safe during pregnancy. And I would strongly recommend that a PBC patient should continue taking URSO the whole time of pregnancy and also breastfeeding. There is no risk for the unborn or the newborn or later on baby. And there, I wouldn't make any differences between the different solutions or prescription forms, whether it's ursodiol or ursofalk or any other urso supplier. I would switch from one to the other more in regard to dosing. So the capsule contains different amount of milligram, and some suppliers have smaller, others have higher milligrams. And so I would rather adapt in regard to the optimal dose, which is 13 to 15 milligram per kilogram body weight, meaning if you weigh 70 kilogram, for example, then the ideal dose would be roughly 1,000 milligram. Now, if you have problems, in particular GI problems, then it could be due to additional factors being, put into this capsule next to urso to keep it as a pill or a capsule. And that can be lactose, for example. So if you're lactose intolerant, then this could be a problem. Then I would switch from one supplier to the other to check whether these additional factors in the capsule, in the pill, are causing the problem. That is the reason when we switch the supplier.
Okay, that's great, thank you. We're just having a wee look for a couple of other questions coming live on Facebook. I'll just have a wee look for those for us. So we have a patient asking about if perimenopause and menopausal women find changes with their livers due to hormonal changes if they have PBC.
Yeah, the hormonal changes certainly play a role. We have that in particular very commonly for symptom burden. So PBC patients with pruritus, they very commonly report on pruritus in the luteal phase, so in the second part of the menstrual cycle. And sometimes this can be very tremendous, and these women tell you I know exactly when, in which part of my menstrual cycle I am. And also if they, undergo hormonal replacement therapy, for example, they have problems with, in particular, pruritus. Now, postmenopausal means that they are at first sight less hormones, so that's less metabolization of these hormones for the liver. So this is at first sight may be beneficial. All these hormones do not need anymore to be metabolized and secreted, and may, be a problem for a cholestatic liver disease. On the other hand, the postmenopausal symptoms can be a problem, and then we need some hormonal replacement. Normally, I do not limit hormonal replacement in my patients with PBC, because the novel treatments rather contain low amounts, and I'm very liberous with those treatments. So in principle, there are alterations, there are many changes ongoing, but in the end, it's an individual decision on symptom burden, on hormone replacement, what should be done in the pre or postmenopausal state of a female person.
That's great, thank you. We have a question around a patient asking at what point should their children be tested or followed for PBC? Should they be tested with blood tests annually? And as noted that one of their children already has diabetes.
Yeah, that's a very good point. We
Something that comes
know,
up quite often actually
yeah,
is patients, should they be considering that for family members?
yeah, absolutely. Absolutely. This is absolutely true. What we recommend to our patients is that, in particular, first degree females, that is the sister, the mother, or the daughter, that those should be definitely screened. And at first sight, we do that for antimitochondrial antibodies and cholestasis parameters. Now, if they are normal, then I would redo that in 5 years. If we find increased autoantibody levels, such as antimitochondrial antibodies with normal liver values, then I would repeat liver tests once annually. If liver tests are increased without the autoantibody, I would look for other causes for that, and would not really believe that it's PBC. And then it needs a more dedicated follow-up. The risk for these first degree female family members is, depending on the literature, somewhere between 5 to 15%. For male patients, it's much less, but still, I think it depends a little bit. I would also send them once around for testing, and if that is everything is normal, is fine, then maybe, yeah, every 5 years again. We don't want to make our patients, our healthy family members, sick. But it has to be kept in mind that if we find autoantibodies, the risk is further increased for developing PBC after a couple of years. Also here, the literature is very divergent. We know that there is an increased incidence in certain families, not in all. It's not a typical monogenetic disease where we can calculate roughly the probability of the next generation, for example, to experience this disease. This is more complex, but there is let's say, a slightly increased risk, in particular for female first degree members.
That's great, thank you. We have another question about vitamin C. Is it okay to take vitamin C?
Yeah, absolutely. I think, this is a water-soluble vitamin. So the vitamin C you take too much, you just secrete via urine. You can acidify urine very well. In particular, women with PBC develop more commonly urogenital tract infections, and bacteria do not like acidic pH in the urine. So I even recommend my female patients with relapsing urinary tract infections to take higher doses of vitamin C. You need to take that at several times of the day, up to 5 grams or so you can take to really acidify your urine without any problem, and that can be of help if you do not want to take an antibiotic right away. You feel the problem when it occurs, for example. So yes, vitamin C is safe. You cannot actually overdose that normally, because the overload is just going out via urine again.
That's great. Thank you. We have another question around anemia. Correct me if my pronunciation isn't correct. I have hemolytic anemia, and in September, hemoglobin dropped to 6. Given 2 units of blood along with going on steroids for 3 months. Hemoglobin is now at 11.7, but they've noticed that the liver function numbers have improved also. How long do you think the effects of going on steroids will last? They've been on steroids for 2 months.
Yeah, hemolytic anemia means that this is an immune-mediated, in most cases, it's an immune-mediated phenomenon. As we have PBC or thyroiditis, this can all be immune-mediated effects. So that's the reason why we treat with steroids in this case. Hemolytic anemia, which is immune-mediated, is improved under steroids. And so I would continue that as recommended for 3 months and then taper the dose and hope that this works, because hemolysis may come back. So I would stepwise titrate and taper steroids. If lab values are significantly increased, that always hints also towards some more immune-mediated phenotype of the liver, and always make me wonder whether there is also an autoimmune hepatitis component. Not necessarily the case. This needs a bit more follow up of work and laboratory examinations. But normally steroids are not beneficial for a real PBC. Budesonide is, but not the regular steroids. They do not really improve liver function tests. So if they are significantly down, then I would check whether these liver values come back once the steroids are tapered or stopped. And then I think this would be a reason, for example, to take a liver biopsy in such a follow-up period where liver function tests rise.
That's
But
great.
otherwise, it's an immune-mediated phenomenon. And if steroids cannot be tapered and hemolysis is coming back, then there are other immunosuppressive regimens which are of help. But in most cases, this is a temporary phenomenon and should not require lifelong steroids. Or I would suggest then to switch to other immunosuppressants if a temporary steroid trial is not sufficient.
Thank you. Another question that we've got coming in, we have a patient who has 10 years ago, they had mild erosive gastritis caused by Nurofen, and then in 2016 diagnosed with PBC. Recently learned they've got mild chronic gastritis and a hiatus hernia. They also have Sjogren's, and they've noticed a build of mucus of sorts at the back of their throat. Should they take medication to assist with the stomach acid, as well as making those changes within the diet?
No, I mean, these, chronic gastritis alterations are seen in many patients without PBC, such as hiatic hernias and so on. This is not related to the liver disease. If there is not a reflux esophagitis or ulcera or erosion in the terminal end of the stomach, the antrum, or if there is no duodenitis, I would not treat that. I would just consider this as, alterations we see in many patients. This can, of course, be triggered by, certain food intake. If patients, take a lot of alcohol, if they eat very hot meals, as in Asia people do, or drink a lot of coffee, then this can be a problem. But as long as there are no ulcera described, if it's only more a histological alteration, I wouldn't treat that. I think this is not needed. If there are symptoms, if acidic symptoms are present, then I would rather take antacidics. So, these gels, these chewing pills, which contain basic substances which bind the acidity in the stomach, and this is of help, and this reduces the amount of um, acid content of protons. They increase the pH value, and that would be something I would recommend in those patients in a dosage as needed, and otherwise no specific treatment.
That's great. Thank you. This next question.
Helicobacter pylori should, of course, be excluded in these biopsies, and or by Helicobacter pylori antigen in the feces.
Okay, thank you. This next question is quite interesting. So the term remission is used in some autoimmune diseases. Can this be achieved in PBC? And if so, what parameters would remission be declared at?
Yeah, remission. I mean, remission, what we think our current understanding is we cannot cure PBC. So we can optimally treat PBC. And if we optimally treat PBC, then let's say 10 years, 15 years ago, we said an alkaline phosphatase above 1.5 or 1.67 times upper limit of normal. So quite a bit above the upper limit of normal, that would be sufficient. We have understood that the ideal treatment goal is normalization. So if lab values are normal, then this is the ideal treatment goal. We wouldn't go beyond, actually. Bilirubin may be, a parameter which the low normal would be even better than the higher normal range, as an exception of normalization. But otherwise, once your lab values are normal, you can be ensured that the life expectancy is as that of an age and gender matched normal population. So in that regard, you do not need any additional treatment, and you shouldn't bother too much about your liver disease. Of course, a liver cirrhosis should be excluded, because liver cirrhosis would be an independent risk factor and should be more intensively followed up than non-cirrhotic patients.
That's great. Thank you. There is one last question that's just come in on Facebook that I'm going to sneak in before we finish, if that's okay.
Sure.
We have a patient diagnosed with PBC on ARSO. Their ALK phos kept going up. Liver doctor wanted to put them on another medication. Rheumatologist put them on check my pronunciation is correct again. Rheumatologist put them on hydrochloroquine for other autoimmune issues. This made their alkaline phosphatase go way down, and they're just questioning whether their liver doctor is telling them they don't have autoimmune hepatitis. So I think they're a bit worried about overlap.
Yeah. So, I mean, the diagnosis, it seems like there are other immune-mediated diseases present, which is commonly seen in PBC. If URSO doesn't do the job, the first question is always, is the dose correct? So is it maybe underdosed? So let's say roughly 15 milligram per kilogram body weight should be taken. If that is the case and liver enzymes still go up, I would definitely consider after a while, before doing a second line therapy, I would consider a liver biopsy to have a better understanding what's going on, to better understand the immune infiltrating cells in the liver, the damage to the bile ducts. Is there bile duct loss? Do they disappear? How much are they damaged? Is there anything else going on in the liver which could explain that the liver enzymes are rising. And then only then, if we see lobular inflammation, if we have other laboratory parameters which hint towards autoimmune hepatitis overlap, or now called invariant syndrome, then that would hint me towards further therapy such as immunosuppressive therapy. Otherwise, if it looks more like the PBC is the driver, then I would go for PBC second line therapies. Obeticholic acid would be in label, fibrates would be off label, and there are many clinical trials ongoing in which I would include such a patient if possible. Hydroxychloroquine is used in rheumatology. Normally, that should not have a benefit on PBC. So it could rather be that a more general inflammatory component is improved by that, and that PBC is secondary improving by the reduced inflammation in the whole body rather than a direct effect on PBC.
That's great. Thank you so much for that. That's us been able to get through all the questions we've had sent in for this week in advance, and also all the questions that have come in live, which is brilliant because often we don't manage that. So I really appreciate that. We've been able to get them through. And thanks again so much for joining us today, Dr. Kremer. We really do appreciate your time to come and spend it with us. And I believe I'll be seeing you at the summit in April.
That's the plan, yeah.
Brilliant. We'll see you there then. Thank you again so
Wonderful.
much for joining. I really appreciate it. Thank
Wonderful.
you.
Thank you
Take
so
care.
much. Take
Thank
care.
you. Bye.
Bye-bye.